Good evening, everybody. Thank you for joining this webinar. My name is Jason Higginbotham. We're going to talk about myopia in terms of commercializing and communicating. I'm going to turn off my webcam now so you can't see my ugly mug. So hopefully you can all see the screen here. A little bit about myself. I'm an optometrist and dispensing optician, just over 31 years in the industry. Formerly, I used to work for Birmingham Optical Group, and I'm doing this on their behalf as a consultant now. I've set up my own company called FYI Limited. Awful pun, I know. I now provide clinical training, education, and a lot more besides to a whole range of companies. So without further ado, we'll crack on. So myopia, it's a topic that's obviously huge at the moment and has been covered extensively by a range of very eminent and notable academics and opticians and clinicians, and certainly I'm not going to try and fill their boots, but as it were. But I am going to try and talk a little bit about the business element of myopia, but a little bit of a recap on certain terminologies and also certain facts and figures. So at present, one of the largest causes of new sight impairment and serious sight impairment registrations in Southeast Asia and Japan is myopia. And in fact, in one region of Japan, an area called Tajimi, myopic macular degeneration is considered the largest cause of new monocular blindness registrations. So it can be, obviously, a very, very serious condition. And there is no doubt that the incidence of both myopia and, more worryingly, high myopia is on the rise. We tend to call pathologic where it's actually causing damage, as opposed to high myopia being pathologic as per se. And I've already mentioned there are areas of the world where it's reached epidemic proportions, particularly Southeast Asia. It's important to consider a few terminologies straight away. Most sources consider myopia to exist when a minus 0.5 diopter SER, spherical equivalent refraction, exists. And most sources then consider high myopia to exist when the spherical equivalent refraction is less than or equal to -6. And when we say less than, we really mean more myopia. Risk factors for high myopia at adult age are a young age of onset and a fast progression rate during childhood. Myopia management seeks to reduce this rate of progression. It's difficult to do much about the age of onset, as according to the recent DREAM study, for example, this is heavily dependent on gender, ethnicity, and parental myopia. Still, factors like time spent outdoors, time on screens and smartphones, and even intense educational attendance can affect this. So communication to parents, particularly those who are myopic in East Asian, for example, is important. And the more we can do to reduce the amount of early myopia and myopic progression, the more we can avoid high myopia. Myopia management, or MM, is now the preferred terminology for the test and interventions clinicians use to help reduce the rate or amount of myopic progression. So in terms of prevalence and numbers, I'm sure you've probably all seen these figures before. In terms of the likely number of myopes by 2050, the prevalence is likely to reach about 52%. And in terms of the numbers of myopes who have high myopia by 2050, that should be roundabout, or roughly, between 900 million and 1 billion people, with potentially 10% of the overall population having high myopia. And ultimately, those figures have come from the WHO and the Brian Holden Vision Institute. And if 1 billion people have high myopia, that's a significant risk to their vision. And where some form of degenerative damage has occurred due to myopia, we might call that pathologic myopia. And the risk factors are considerable. And of course, we want to obviously avoid that. So myopia itself is a problem for people in that they require visual correction for many daily tasks, including driving, and uncorrected refractive error particularly myopia, is a major cause of preventable visual impairment in the world. And high myopia has far more serious implications beyond that inconvenience. It can cause obviously a large range of sight or potentially sight-threatening conditions. But sight impairment itself from that can lead to reduced quality of life, depression, higher incidence of falls, and even a higher risk of dementia. So the long-term health effects overall cannot be overlooked either, and the human cost could be catastrophic. And for me, the problem is that the public aren't really aware of this. I'd imagine if you ask the average patient about glaucoma, cataract, AMD, or myopia, most will have little knowledge of any, but perhaps even less understanding of the clinical existence of pathologic myopia. To most people, myopia is merely a refractive issue and nothing more. It's inconvenient at worst for the majority of myopes. Pathological myopia, in terms of that starts at very early age, represents about 0.9 to 3.1% of the population, with rapidly progressing extreme eye elongation, with myopia well in excess of -6. And to those people, myopia is a very real issue beyond simply thick spectacle lenses, and the prognosis is often not good. Conditions like myopic macular degeneration, retinal detachment, cataract, glaucoma, and more besides can occur. Personally, the largest prescription I ever refracted was during my pre-reg year in a practice in Liverpool, and it was -43 spherical equivalent refraction in diopters in both eyes, roughly. And the lady in question was elderly and had at best 660 binocular VA. I referred her for lens extraction at the time, cataract, and in the better eye, post-surgically, her prescription had dropped to about -5 SER. And she achieved a best corrected visual acuity of 624, and she was absolutely overjoyed. Most impressively for her was the move away from immensely heavy glasses. I believe it was called the Roble Superlenticular, made of glass at the time. So there are, of course, economic implications for myopia. The global prevalence, as we've already said, is expected to rise significantly. But the cost to the UK economy in 2010 was pretty significant, around about £22 billion a year for sight impairment and severe sight impairment. A more recent study published in 2019 suggests that the cost of the UK from sight loss has now increased to 36 billion, or had then increased. But last year there was a drop of roughly £750 million due to reduced use of services. What isn't fully understood yet is the likely effect COVID has had on myopia itself. Many sources suggest a detrimental effect due to more time spent indoors and likely greater use of screens, etc. And some, however, wonder if the reduced engagement with education and greater appreciation of outdoor exercise time might actually have had a positive influence. It's hard to say. Also, the correction of myopia is expensive for patients, but that, of course, may be a benefit to opticians' practices. In Asia alone, it's estimated that the annual cost of myopia correction is $328 billion US. And so the cost globally, economically, cannot be underestimated. So we're going to go to our first poll question quite early, and it's a fairly direct one, and that is, are you currently providing myopia management in practice? Well, basically, according to this, about 53% of people aren't providing myopia management in practice, and 47% are. So roughly half. That actually slightly surprises me, because that's slightly more in terms of those providing myopia management than I expected. But that's actually good news. That's really great to know. Sorry, I realized that people could see that. So I'll move on there now. So let's have a look at the effect of myopia. And this is taken from the Global Myopia Symposium of last year. And it's the increasing odds of comorbidities. And the four of them, the major ones, cataracts, retinal detachment, glaucoma, and myopic maculopathy, also known as MMD, myopic macular degeneration. And as you can see with the lower prescriptions, -1 to -3, that still increases the likelihood of those conditions to a moderate extent compared to basically not having myopia. And likewise, -3 to -5, as you'd expect, the the risk or the odds, I should say, of those particular conditions increases, but it becomes exponentially higher when you get to the high myopia prescriptions, certainly above -8. You can see massive risk, really, or increased risk, I should say, or odds of developing myopic maculopathy. And particularly the odds of suffering retinal detachment and MMD are considerably higher. We cannot halt or reverse myopia, at least as far as we know now, of course. However, myopia management aims more than anything to reduce the chances of a patient reaching high myopia in adulthood. And that's really the key aim of providing myopia management. Here again, you can see the increased odds of visual impairment with increased axial length. And once again, as you'd expect, it's quite an exponential increase in the odds of visual impairment when you get to the very high axial lengths. Recently, however, I saw a couple of very interesting patient results from the Oculus Myopia Master, actually, and the device showed they had minimal amounts of myopia as far as refraction was concerned. But for their young age, they had much higher than average axial lengths. And the reason for the low prescription was that they, both patients, siblings in fact, had very flat corneas. So that negated the effect of the long axial length as far as the prescription was concerned. But that doesn't take away the fact that the axial lengths were long. And obviously in later life, they could be much longer. And so for me, this introduces a range of important clinical questions. Should we screen the axial lengths of all children? Should we screen or measure at least once the axial length of all patients? Because I've got very flat corneas, and I'm sure many other patients have. Obviously, maybe not a high proportion, but it could be a reasonable number. Should myopia management therefore be based on axial length and not prescription? And I know that this question has been asked by academics already, and some have suggested that axial length should be the primary identifier as opposed to obviously the prescription itself. But I don't yet believe there's a fully agreed upon consensus on this. But also, how many cases of sight impairment and severe sight impairment could be due to long axial length and perhaps put down to AMD, for example, in later life? Is axial length something that should become a mainstay of eye care clinical practice? How much effect does it have in terms of general eye health? And from myopia studies alone, you'd expect clearly from what we can see from this chart that it clearly does have some significant effect. So how can optometry respond to both the clinical and economic implications of myopia? Well, obviously, do all you can to prevent myopia progression in as many patients as possible and avoid high myopia wherever possible. But also, from a practice perspective, do all you can to increase revenue streams from myopia. Now, most, if not all, clinicians would agree with the first box, but I would just wonder how many would agree with the second. For me, an optometrist must consider the commercial elements of their job or business as much as the clinical elements. Is this controversial? I don't think so. It could be argued that as you have a duty of care to look after your patients who come to your practice, it could be implied, therefore, that you have that duty of care extends to continuity of care and essentially sustainability. Continuity of care relies on the business being profitable and being sustainable. And therefore, your duty of care is as much about making money for your business as it is to care for your patients and their ocular health. So here's another quick option here, a case scenario based around that. So for example, a 4-year-old patient comes to your practice with a -2 diopter spherical equivalent refraction, and both parents are myopic, and year after year with increasing myopia, all that happens is spectacles are provided or contact lenses, etc. When I say you, I'm not talking about any one individual, of course, but this particular optometrist doesn't mention during these eye examinations the current knowledge that is out there on myopia and the myopia epidemic. I've called it pandemic, of course, and no notes are made or thorough notes aren't made about this. And the child returns annually into their adulthood, and they return roughly age 25, and they've now got a -8 diopter spherical equivalent refraction. But this 25-year-old patient is well aware that you should have known about the risks of progressive myopia when you first saw them as a child, and that their parental status made this even more of a priority. And now they've heard an advert from a legal firm, and after contacting them, the practice is being sued for clinical negligence, and the GOC have been informed as well. Now, this might sound like scaremongering, and in a way, I hope it is, but myopia is a recognized cause of vision loss, rather like AMD, glaucoma, and cataract, for example. We always try to detect these conditions and refer where appropriate. Where we can treat, we'd like very much to do that. Firstly, because it genuinely helps the patient and is part and parcel of what patient care is all about, but also secondly, it's how an optician's practice makes more money. That is what we should be doing. But also, we do it with dry eye disease, and we also charge for OCT scans, for example. So why shouldn't we make money from myopia? Beyond that, the World Council of Optometry has introduced its standard of care for myopia management by optometrists. And so simply correcting the refractive error is no longer sufficient. Myopia management should not be optional and should really be an obligation of optometrists according to the WCO. And three major words that I picked out of their recent report are mitigation, measurement, and management. So mitigation, optometrists education and counselling parents and children during early and regular eye exams on lifestyle, dietary and other factors to prevent daily onset of myopia, or delay onset of myopia, I should say. Measurement, ultimately optometrists will be evaluating the status of a patient during regular comprehensive vision and eye health exams, such as refractive error and axial length, whenever possible. And management, addressing patients' needs of today by correcting myopia, but also providing evidence-based interventions like contact lenses, spectacles, pharmaceuticals, and so on, that will hopefully slow the progression of myopia, ultimately for improved quality of life and better eye health today and into the future. So not only corrected vision, but also including public education and early and frequent discussions with parents and, of course, the children that explain what myopia is, lifestyle factors that may impact myopia, the increased risks to long-term ocular health that myopia brings, and the available approaches that can be used to manage myopia and slow its progression. So really, optometrists need to incorporate myopia management as a standard of care into their practice. Certainly, that's what the WCO implies. So if you haven't already, a myopia business strategy is a good idea to undertake. So, of course, part of that will be to acquire equipment to undertake myopia management, to decide on the therapies that you want to offer, think about practicality, the evidence availability, and so on. Set your protocols for screening and commencing treatment. Look at the evidence base. Training and competency. You know, are you fully trained up with those particular therapies and in terms of taking certain measurements? Do you feel confident and competent? So get used to it basically, and then practice and perfect your art ultimately. Get better at it, maybe prior to launching full-on clinics. Perhaps see specific patients and build up that skill and that knowledge. And then consider, of course, your pricing structure and diary. And of course, that will vary depending on the products that you use, of course. And tailor your history and symptoms and the eye examination itself for specialized myopia appointments, myopia management appointments in terms of initial appointments and, of course, follow-up and monitoring. And consider that, therefore, as I've already mentioned, the aftercare and follow-up structure and what things like questionnaires and other elements of history and symptoms on follow-up exams that you might need to include. And of course, look at a marketing strategy. Are you able to get it out there, not only to your existing patients, but to the local community and maybe even beyond, to obviously let parents and patients know that that this problem exists, and B, that there may be some way that the progress of myopia can be slowed. And of course, engage the patients and the parents, produce a range of reporting and monitoring. And if you take all of these elements into consideration, the key thing is communicating the need for myopia management to your patients, and more widely, the professional bodies, the government, and even the manufacturers, perhaps along with large optical companies, need to get the message out to parents schools and beyond. And this is, of course, most vital and important in areas like Southeast Asia, but it is no less of value in the UK and Europe, for example. There is some doubt that myopia will ever reach the same epidemic levels here in Europe and the UK as it has in the southeast of Asia, for example, primarily where there is a genetic and ethnic and frankly intense educational element that plays a part. But ensuring patients don't reach high myopia, or at least have lower prescriptions in later life, is really important. And these people will often become very loyal patients and will generally recommend friends and family as they get older as well. So now we'll move to the next poll question, and basically that is, do you currently use an optical biometer in your practice for myopia management? Yes or no? Right, now that's an interesting result. A tiny proportion of people actually have an optical biometer in their practice. Majority don't, and that's pretty interesting actually. That I wouldn't say that surprises me, I have to say, but I did expect it to be slightly higher, and that's really interesting. So going back to those elements that we just saw on the previous slides, in terms of the different parts of the business strategy, let's quickly look at those individually. So first of all, let's have a look at acquiring equipment. It's very, very clear that an optical biometer is essential. Many studies, many of the key individuals in academia, from the likes of James Wolfson to Mark Bullymore and many others around the globe, Kate Gifford and so on, and all the different reports from the IMI and different organizations suggest pretty conclusively that optical biometer is essential for myopia management, and preferably with refraction and reports. It would be good if it also had keratometry built in, and maybe an autorefractor, and really ideally a topographer as well if possible, ideally with myopography. Now that might be 2 devices or 1 device. There are few, if any, devices that I'm aware of that have refraction, biometry, keratometry and the questionnaires built in, but I think there's 1 available, and I believe there is 1 device available that has the topography built in, but I'll cover that off in just a moment. For me personally, I think it would be nice also to have OCT, because remember, you're going to be looking at people with, well, potentially with high myopia, so you want to check for things like retinoschisis, for example, and likewise, if you've had ultra wide field imaging, again, you might be able to spot some of the peripheral degeneration more commonly associated with high myopia, and of course the increased risk of retinal detachment and so on. Automated accommodative lag measurement is quite nice, easier than doing it manually, I guess, and some form of comprehensive binocular vision analysis would be good, whether that's on charts, built into charts or into instruments, or you just do that in a more standard way, of course, is a different matter. But there are several key devices currently available for myopia management, and the main ones being the Oculus Myopia Master, which does have biometry, refraction, keratometry and questionnaires. The Topcon Maya is another device which is available, which has got biometry, keratometry, topography and questionnaires, but not the refraction. And the Hargstrike Lenstar Myopia has a biometry and keratometry and questionnaires, but not the refraction or the topography. There are, of course, other providers that have existing optical biometers that are more traditionally used, for example, in IOL calculations, such as the Zeiss IOL Master or the Nidec AL Scan. So deciding on therapies, ortho-K is effective, and there's lots of evidence to back this up. Peripheral myopic defocus blur contact lenses or similar spectacle lenses are available, plus different types now of spectacle lenses. Low dose atropine, 0.01%. Multifocal contact lenses or spectacles or extended depth of focus, for example. Modified spectacle prescriptions, a lot of evidence suggests that's not necessarily useful. And of course, combination therapies. And there have been 2 very recent cases regarding atropine in New South Wales, Australia, to the Pharmacy Council of New South Wales about what they call compounded atropine eye drops, which are generally made by pharmacies at a request of optometrists and other clinicians. One complaint concerned 0.1% atropine provided by a pharmacist, where the patient complained of headaches, eye aches, photophobia, and blurred vision. And another complaint was about the drops being formulated in non-sterile conditions. And it was also clear that some pharmacies were prescribing 1% atropine. And this, and the dose, of course, should be 0.01%. And there are other eye drops that are being trialed or even in use in some areas of the globe. But again, here in the UK, they're not licensed, as is atropine isn't. There are more types of spectacle and contact lenses becoming available all the time, like EDOF, extended depth of focus contact lenses, which were originally designed for presbyopes, for example, or the new Essilor Eyezen lenses, or the Hoya MyoSmart. And Hoya have just announced a joint effort with Wolf Eyewear, for example. Zeiss and others have also produced spectacle lens options, and I know that Cooper Vision and Alcon, for example, have got contact lens options. So you have to learn what you think worked best for your patients and their needs, and what you're happy to actually offer to your patients. And consider contact lens aftercare, for example. Look at what the child does. How much do you need to charge for these therapeutic options as well to be profitable, but also to remain affordable for the patient? In terms of protocol, assume that all kids are at risk, I would say. Involve the parents. Myopia questionnaires are available on some devices, but you might want to formulate your own. Assess the refraction initially with perhaps cycloplegia, and of course measure axial length and keratometry. And combine clinical and non-clinical data and compare against risk tables, and really get the parents involved in all of this, of course, and establish a baseline and review after the first follow-up to understand the progression risks fully. And this is where, again, communication is important. When do you start? Should you discuss risks and other factors with all myopic patients, even those much older? How far do you go? It's an interesting discussion, ultimately. Personally, I think it's worth discussing with myopic patients if they have children or intend to. And beyond that, you may even discuss if they've got myopic grandchildren, perhaps. History and symptoms obviously need some revision for these purposes, and establish if those children need certain screening, perhaps. Maybe you should screen every child and then establish whether or not they need full myopia management. So some form of screening for all kids might be prudent, and from there you can advise if you suggest a full workup, for example. And training and competency. Do you understand the causes, risks, and treatments? Are you confident to offer Ortho-K, for example, or other types of contact lenses, etc.? And what are you happy to provide, basically? So to be prepared is the key there. And practice and perfect your art. So review the results of all your myopia management patients, and check and review the effectiveness of the treatments that you're offering against specific patient parameters like ethnicity, parent profile, age of onset, lifestyle, etc. And develop a rationale for changing initial interventions, maybe for either different patients, or reviewing after follow-up, maybe switching to combination therapies and so on. But of course, don't give up at the first hurdle. Try and find something that helps to slow the progress. You can't reverse it, obviously, but if you can reduce the speed of progression, you might get to a point where the patient doesn't reach high myopia in adulthood, which is, of course, the primary aim. Primary structure and diary. We know that the GOS fee isn't fit for purpose for anybody, frankly, but particularly for kids, I guess. But consider not only the cost of the product, but also obviously the chair time required. You would probably have to charge a significant top-up on top of the GOS fee for the product and for follow-up appointments. What about maybe some form of remote follow-up where possible, even if it's just a quick questionnaire? Eye care plan schemes and direct debit schemes could help it to be more affordable for some patients. But there is a point where some people might not be able to afford it for their children, and that is a worry. And tailor your eye exam. So of course, the use of the questionnaire, but why not use pre-visit triage, maybe some form of online software or online platforms to help parents and patients to understand more about the condition, maybe on your website, but go beyond that and try and work out if they're already myopic and what their vision is, their acuity is, etc. And ensure, therefore, that parents come armed, as it were, with information about their kids and about themselves and even their parents. And of course, then, in terms of tailoring your eye examination, when you have to assess axial length, probably the cyclo RX, Ks, binocular vision, competitive lag, genetics, lifestyle, etc. What about the appointment time? It's going to take longer. Again, communication helps further here. Practice posters and leaflets help certainly in getting people engaged. Info in emails and recall letters, of course, is valuable. I imagine that your practice websites and in particular social media is where these days the greatest impact can be achieved. And perhaps practices and the wider industry need to target all users of eye care directly through social media, but also try to engage parents and maybe even children directly through social media. And of course, what about schools? Who should try and engage with schools? Local optical committees, the GOC, Public Health England, Scotland, Wales, Northern Ireland? It's an interesting question, that. And catching the preschool children's parents, as it were, to try and get them to engage in very early eye screening for their children, for example, might be of benefit. But of course, is there capacity in the local community eye care to cater for this? And is there the appetite? You might hear my computer fan being very noisy, by the way, so I apologize if you can. What about aftercare structure? Obviously, review the results of all of your myopia patients, but how are you going to review it? I've already mentioned this to an extent, but how are you actually going to review in terms of your follow-up? How often are you going to do a follow-up? And in terms of the results, will you then extend that follow-up period, or will you get them back even sooner? And design a full marketing strategy. You've got to get the parent buy-in, perhaps more than the patient, because kids obviously don't really care often. Be loud and proud about it, get the word out there. Beyond recall letters, social media really helps, and I've already mentioned obviously practice posters, etc. What is the wider profession doing though, and where is the national coverage? And reporting, that certainly helps. It helps to get the message out there, and it helps to certainly improve the buy-in from patients and maintain, hopefully, regular visits to hopefully slow the progression through myopia management. So of course, again, review all the results and hopefully go beyond that. So that leads to our third poll question, which is which therapies, if any, would you be prepared to offer to your myopia management patients? And obviously try and tick all that apply if you would. Okay, so mainly contact lens and spectacle based, but quite a few doing or prepared to do ortho-K or actually doing ortho-K. As I'd expect, less people prepared to do or use atropine because obviously it's not really licensed at the moment, and combination therapies, again, a reasonable number. So there's certainly a will or a desire to use these therapies. As one would expect, the soft lenses of some description and spectacle lenses are going to be the most commonly used. So let's progress from there now onto the justification really for myopia management. I think everybody's answered now. Yeah, looks like it. There we go. So myopia management must be rewarding financially as well as professionally and maybe even spiritually for some practitioners. So to justify it, it's got to meet that, and patients will likely remain loyal and will need glasses and contact lenses for many years to come, hopefully be at your practice. And of course, where patients do have high myopia or moderate myopia even, they'll require slightly closer monitoring, I would suggest, because they're obviously at higher risk of pathological conditions resulting from myopia. And of course, it's our duty of care to do that. But there will be, for some people, barriers. And this is modified from an interesting paper from 2019. And the barriers tend to be financial or from a lack of, shall we say, education and training, problems with public education and awareness, practice issues, and others. So in terms of financial barriers, these will include the patient and parent affordability. It might be limited. Return on investment may be deemed too low for a practice. Certainly the GOS fees won't cover it. Is there more government money? Maybe. The cost of equipment can be quite high up front. Is rental available? And if you do buy equipment up front, there are circumstances where you go over a certain capital expenditure, CapEx, and you might again trip what we call de minimis on VAT. The worry with the cost for patients, though, is it's feasible that a two-tier system could operate where poorer children are actually at higher risk of pathologic myopia than their wealthier peers through no fault of their own. And that is worrying. And the return on investment may not always be immediate, and it might be hard to fully measure. But of course, remember, long-term practice growth certainly could be a major benefit of providing myopia management. In terms of training barriers, it's a fairly recent development, myopia management in optometry, and some people might be daunted by it. Those who are recently qualified might have less experience of practice and limited training on myopia, and those with little postgraduate education might also be a little wary of it. Will there be a professional certificate in myopia, perhaps? A few people feel the evidence is still not strong enough. There's not enough consensus on cause and therapy. I think it's clear that in Europe and the UK, it's not going to reach epidemic proportions, but I think it's also very clear from the World Council of Optometry that it has to be taken seriously and become part and parcel of daily practice now, myopia management. And some clinicians just don't feel confident with the therapies. It's clear that the university optometry degree courses already have, shall we say, too much to cover, especially now with the uptake of OCTs into practice as well. But dry eye disease and myopia management are all further things to learn beyond graduation day, for example. Public knowledge barriers. Patients and parents are often completely unaware of the risks of the, I've said pandemic, I should really say epidemic. And there's a lack of press coverage, I would say, a lack of clarity and scientific substance on social media in some respects. There's plenty of evidence and communication within the academic community and within the profession, of course. There's no obvious reporting by the NHS or public health to schools, local authorities to warn them about this, in my opinion, and probably not enough attempts to engage with children at their level to make them more aware of the possible consequences of using smartphones for too long or holding things too close and not getting outside enough and things like that, not having enough breaks. And there might be a lack of understanding in the public that treatment, or shall we say, therapy might be available. And some parents might think, what's the point? They're myopic and they've got no problem, so why would it be a problem for their children? And unless you make it very clear that it's not a cure, perhaps some parents and patients may fail to see the benefits. But making it very clear that high myopia has got significant risks and that you can help to avoid that, that should hopefully bring people on board. Practice barriers. Some clinicians just don't want to get involved. They might not think there's a demand, or they may even be getting towards the end of their career. There's no license, for example, for 0.01% atropine in the UK at the moment. Some practices may just feel that they're too busy to engage in MM. Some might think that we don't have yet the necessary devices, or perhaps they take up too much space. Maybe the average income per appointment or per patient is better when you see, shall we say, wealthier presbyopes, for example. But you've got to think about practice building as well. And continuity of care. Patients might move or don't return, or of course, likewise, you might have a lot of locums, so you can't give that continuity to your patients as easily as you might want to. But until the revenues for myopia management are high enough, or there are enough regular fee-paying patients, and obviously GOS only allows for a 6-month recall for myopia at the moment, there may be a lot of reticence from clinicians to potentially reduce average revenues per appointment and per clinic if they do myopia management as a result of seeing more children. And they might not have the room or the free clinic time and space to put on extra devoted myopia management clinics. And of course, GOS is clearly one major stumbling block here, and I think in all honesty really poses a true and significant public health risk, really, in terms of myopia management. Other barriers might be that there's a limited patient database in your practice and that most of the patients are elderly, for example, and that might vary between urban and rural areas as well, or practices have already purchased recently other devices or may find other services or devices more profitable to the practice. And that recent investment may mean that they can't afford to take on maybe an optical biometer, perhaps. And some might think that it's morally difficult to charge children for what they believe is essentially something they should be getting free, and that certainly is an interesting point that I've heard before. And that leads to the final poll question now, and that is basically, do you think it's worth providing myopia management to your patients? So yes, almost everybody thinks, well, I think it's everybody there thinks it's worth providing. There might be a handful that don't, but ultimately the majority, the vast majority, do think it's worth providing, and I would obviously have to agree with them there. Again, interesting to know though. So conclusions, there's no doubt that myopia is a global health problem, and there really is no doubt. Therapies exist, and lots of studies, of course, back these up, that these therapies can be effective in controlling the rate and amount of progression of myopia. And the ultimate aim is to try and avoid pathologic or high myopia, really, in as many patients as possible. And the future human and financial cost of this is really too high to ignore. My worry, and it's clear from some of the answers today that it's an unfounded worry, but would myopia become another climate change? Will there be myopia deniers? I hope not, and I'm sure clinicians won't do that, of course, but optometrists really should engage in providing screening for myopia according to the World Council of Optometry, and they should either directly provide the therapies and advice, or maybe at least inform the patient and parents of the risks, and maybe even refer them on if they don't want to undertake myopia management. I think lobbying needs to take place, and I'm sure the professional bodies are doing that, but and obviously they're certainly doing that in relation to the GOS fees. I think we'd almost all agree that they are almost insulting in reality compared to other primary care professions. And when it comes to a clear major public health crisis, which I think you could probably say myopia is, perhaps not necessarily in the UK and Europe, obviously in Southeast Asia, but you don't want it to become that problem elsewhere. There's got to be a review of NHS funding for myopic children and young adults, and really every child should be screened for myopia from an early age. The problem, of course, is those who can afford private care will potentially be at a lower risk of high myopia in later life, and of course those on lower incomes might therefore be at higher risk. And so I suppose the ophthalmic sectors, ophthalmology, optometry, and so on, dispensing opticians and even orthoptists must unite, I suppose, and then align their message to maybe lobby government and get the professional bodies as well to do the same, to acknowledge the science and the threat, and hopefully that will result in more funding for certainly children's eye care in other parts of the UK, particularly England, Wales, Northern Ireland. Scotland's a little different, but even there it would need to be addressed. And hopefully myopia management awareness will become greater in the public and lead to hopefully more people getting involved in having myopia management interventions. So that's the end of this brief webinar. Brief might be the wrong term when I get involved. Has anybody got any questions? Somebody's put, we operate a treatment plan with a deposit. How would you explain the price to a patient regarding the treatment plan? Interesting question. Well, obviously I can't describe the elements of the treatment plan because I don't know what they are. However, in terms of describing it to a patient, the first thing, of course, is to briefly discuss myopia. And I think recently, Myopia Profile released a very, very good mini poster, which could be a very easy way to introduce it to the patients and obviously their parents in many cases, to get them to understand what myopia is and what its actual risks are for in later life, and let them understand that it requires long-term care, and hence why you've got to obviously pay for the upfront screening and the initial appointment to set up what the therapies may be and what the course of follow-up may be, and that they have to understand that, of course, there are costs to a practice, the cost of not only the equipment, but the cost of your professional time. I would always say you wouldn't expect, I used to say this in practice many years ago, actually, when patients would often complain about certain fees. And I'd say, well, do you go to a dentist, I used to ask, and they'd all almost invariably say yes, and say, have you ever had an x-ray at a dentist? And say, yes. Have you had another x-ray? And they say, yes. Did you pay for both? Yes. And the simple and almost maybe a little cheeky question in a way, but they are simple questions that really introduce the fact to these people that we are part and parcel of primary care, and it's often misunderstood by some patients, and I think that gets it across. And then the fact that they're able to spread the treatment really means that you're doing what you can to facilitate a good continuity of care, because you care about the patients and the outcome of their eye health. So hopefully that would get them engaged. So somebody's asked, have you got any more resources for learning more about myopia management? I have provided some, but I would strongly recommend going to one particular place, is the Myopia Profile website, Dr. Kate Gifford's website. Apologies to anybody else if you wanted me to recommend theirs, but that's a very good resource, and you can sign up to newsletters. Oculus have a really good website, actually, with some very, very nice practice-based advertorials, etc., which are quite useful. Somebody said, any suggestions where we can get myopia management training? Well, at the moment, no, but I'm sure that that is going to become more and more prevalent. I know that there's something happening. Is it likely that atropine will be licensed in the UK? I would be surprised if it didn't, particularly because it's such a low dose. I believe that some people are considering using it, or may even have the opportunity to do so, maybe if they've got IP, etc. But I've not come across anybody personally who's using it. In terms of the protocols for treatment, probably speak to the College of Optometrists and the General Optical Council really regarding that. Good question. What age should you start myopic management lenses? Well, how long is a piece of string, really? I suppose that's what you have to decide in your practice. When are you prepared to undertake the first appointment, and will it be meaningful? Very, very few children are born myopic. Most children are born hyperopic and will gradually, if they're going to become myopic, gradually emmetropize and then go further. So for me, I would say 3 years of age is probably a good starting point, but if you're prepared to start earlier, then great. You've got to remember how easy is it going to be to actually undertake certain measurements on a young child, and getting them to sit still for any short period of time even can be quite problematic. How can you get involved as a locum? Well, it depends if you're doing regular work or not. If you are a locum, become familiar with the main devices, particularly, I believe, the Oculus Myopia Master, the Topcon MyAR, and the Haagstreit Lenstar Myopia. Get familiar with the primary therapies and the primary lens types. So there's obviously a huge range already now of different spectacle lenses and soft contact lenses. So get to know those, understand them, and maybe if you're going to be going to a practice prior to your visit, find out if they're doing myopia management and how they're doing it primarily. What would be an actual reasonable charge on top of GOS? That's another interesting question. Depends to an extent, I suppose, where you are and how confident you are in doing it. If you are one of the, shall we say, superstars that are out there, the likes of, I don't know, Brian Tompkins and Kaya Patel and Sandeep Doshi and Nick Rumneys of this world, these people, and there are many more, Andrew Price and many, many others. Apologies if I didn't mention your name out there, the great and the good, shall we say. Then I imagine you could comfortably charge significant amounts, and you've got to think about the return on investment. So probably on top of the GOS, maybe it's £100 for the first appointment. It might be more. I know that some people are charging £200 for a dry eye appointment with one follow-up and a little bit of product. And I know that's for older people who may be more prepared and willing and able to pay that. But there is a cost to your practice. Somebody suggests, my understanding of myopia management is that we are obliged to make the patient aware, but also have to make the patient aware that there is not enough evidence of a long-term effect. Well, the recent information from the World Council of Optometry certainly contradicts that, but it is an interesting point. Not enough evidence of the long-term effect. That is an interesting one. I would say there might not be much evidence of the long-term effect in the UK and Europe as to how many people will reach high myopia and have pathological results, but there's no doubt about what the results of high myopia are, and that there is an undoubted increase in the prevalence and rate of progression of myopia around the world, but of course particularly in Southeast Asia. Do high myopes have laser correction, still be at risk of detachments? Absolutely. It doesn't change the axial length. All it's doing is flattening the cornea, which is of course what I was mentioning earlier about children who have physiologically flatter corneas. You might, if you only measure the RX, you could miss long axial length. And I just wonder how many older patients with, for example, AMD have actually got MMD. But because they've got flat corneas, they're not essentially myopic. How repeatable are axial length measures on young children? Well, as long as they're fixating on the target, very repeatable. All of these optical biometers usually use what we call partial coherence interferometry or low coherence interferometry, and they're very, very repeatable. How soon can results be seen with myopia management on average? Very, very good question. That's a difficult one to answer, because in a way you'd almost have to do a disservice to the patient if you start the monitoring early enough. You'd almost have to not treat and see how fast it's progressing before you then compare the rate of progression to after you've treated. So it's a difficult one to answer in terms of how soon can results be seen. But if you look at certain studies, COMET study, and for example, and there are dozens and dozens of others, I think NICE study and DREAM and CREAM, etc., are all out there. There's tons of them. They show that it does slow down the progression quite considerably, and you might see that within the first year. Minimum RX that you start to advise, that's a good question. Well, myopia officially begins with minus 0.50 diopters SER, but I think that's probably too early. If you look at the tables, -1 to -3, you're already at slightly higher risk of certain comorbidities. I think a lot of people would say depends, of course, on the family history. So if both parents are hyperopes and the kid doesn't, the child I should say, does get outside quite a lot, then maybe you won't even start at a -1. But if both parents are myopes, reasonably high myopes, and shall we say from an ethnic perspective, the family, as it were, is of Southeast Asian descent, then you might start at -1. Where do we find the evidence studies showing MM is successful? There, well, I'd start with the IMI, the International Myopia Institute. They release annually a massive digest of very, very useful papers, and then go from there, because you will find an enormous amount of references and links from those that will show you almost limitless evidence and studies to show that myopia management is successful. The key is you can't stop myopia, you can only try and slow its progression, obviously. What is the price range of an optical biometer? Well, it depends. If you're just buying an optical biometer, they might be fairly affordable. Potentially, maybe off the top of my head, and don't quote me on this, maybe below 10,000 perhaps. But in terms of upper limit, maybe, again, don't quote me on this as it were, maybe 25 plus. But again, it depends on what the functionality is. It could be that takes the place of several other devices, of course. Can we mention reduced risk? If it is my understanding, there is no proven data to confirm reduction in myopic pathology from myopia control. That's an interesting question. If you, well, so that's a difficult one to answer, because nobody's been performing these studies for long enough, in that have they been able to look at children with lower adult final, shall we say, myopic prescriptions, and then look at the prevalence of comorbidities. The problem is, it's you're damned if you don't, as it were. You have to, in a way, because you can't take the risk. We absolutely know that there's a higher incidence or risk or odds of considerable problems like myopic macular degeneration, cataracts, retinal detachment, glaucoma, etc., from high myopia. We also know from many studies that myopia management can significantly reduce the number of patients that will reach high myopia. And so the two are almost absolutely linked. I think it would be potentially dangerous, and certainly the World Council of Optometry agrees, that to continue to try and wait for more evidence, perhaps. I guess in a way, that is where it almost does become another climate change. Literally 50 years ago, people were banging on about it, but it's taken this long for people to even begin to start doing something about it. I know it's not the same in that regard, but there are some similarities there. Should we be providing myopia management without biometry? Personally, I would say not, and I think a lot of key opinion leaders on this would agree. I'm not one of those, by the way. I'm not a key opinion leader on it, but a lot of big names are, shall we say. And definitely, yes, somebody's put, I had thought this was a more important factor than refractive error. Absolutely, and as I've already mentioned, if you've got a flat cornea and maybe a long axial length, there may be no refractive error in terms of myopia, but a long axial length obviously would be present. It says here, will you be prescribing well into adulthood? Well, certainly you'll be prescribing myopic correction. I think most people suggest that by the age of 25, myopization will no longer occur. There are some forms of, shall we say, truly pathological myopia that will just almost won't stop. And certainly in the past, when I was a dispensing optician 30 years ago, I remember prescribing -28, a Rodenstock lens. And obviously you're going to be prescribing, but you can't be prescribing something that's going to try and reduce the progression. You've just obviously got to do something to help them see, as it were. But I believe up to the age of 25 is certainly suggested by some. Others say up to the end of the teens. Tapering off is a good question. When do you start? There have been a lot of studies on atropine that have shown significant rebound from that, with lower rebound from things like Ortho-K, etc., which is why Ortho-K might be a better option. And of course, in some cases, although we know that the therapies work, it's true that there's no absolute understanding of what is actually happening in terms of the effect of the therapy, how it's actually doing it. A lot of questions there. That was good. Any more, or is that everybody? I'll quickly show references, just as a couple of pages there, just to show people there as well. So thank you very much indeed for joining us this evening. Really appreciate the attendance. Just over 500 attendees, nearly 550 at one point. So that's a fairly good number, I believe. So I'm glad about that. I hope people found that interesting to some degree and useful. I've tried to keep away from all the clinical stuff. Much as I love doing that, I thought I'd try and do something a bit different. And I actually reached out on LinkedIn quite a while back now to see what people thought. And this seems to have been a bit of a consensus that it needed to be done. I hope I did it some justice. So thank you very much indeed.